We'll move on to the next topic. For the next topic, I would like to invite our chairperson for the talk, Dr. Ramandeep Singh. Dr. Ramandeep is a senior consultant pediatric hemato-oncology at Max Super Speciality Hospital. Welcome, sir. And over to you to introduce our speaker, Dr. Sarita Dipani, and the topic for the next session.
Hi, good afternoon. I hope you all can hear me. Thank you, Vasudha, for the invitation. It's a pleasure to move to the next topic after an excellent talk by Girish. Dr. Sarita, who is currently a consultant pediatric oncologist at Southampton, having finished her training in the London Deanery and then subsequently did her research fellowship both at Great Ormond Street and the Clinical Trials Unit in Birmingham. More importantly, she has been involved in the recent germ cell tumor grant application for CCLG and CRI and the MAGIC Collaborative. On a personal note, I came to know Dr. Sarita quite a few years ago when she was doing some work in Malawi. And I know she's worked on Burkitt's lymphoma and probably some non-cancerous conditions. And we roped her into the abandonment working group at that time, which was an area of interest. So with that preamble, I would invite Dr. Sarita to please share her experience on extracranial germ cell tumors. Thank you.
Thank you so much, Ramandeep, and nice to see you again, as you said, after many years, to have you here. So I'm just going to share my screen. Can you see that?
Yes, we can see it, Sarita.
Oh, brilliant. So as that very kind introduction from Dr. Singh, thank you so much. So I'm Sarita Dipani. As introduced, I'm a consultant pediatric oncologist at Southampton Children's Hospital in the UK. And I had the real pleasure of working with Vasudha Rao when we were working together at Great Ormond Street Hospital. So I'm really delighted to be invited to this seminar you've got so many participants here, which is great, especially for a kind of Sunday. So thank you for inviting me. What I'm going to do today is give you an update on extracranial germ cell tumours. So I'm just giving an overview because this is such a heterogeneous group of tumours, just kind of an overview again of sort of histology, location and age. And then thinking a little bit more about kind of new advances in tumour biology, also kind of risk stratification, what the UK experience is, because for a long time we've been using carboplatin rather than cisplatin for the treatment of paediatric germ cell tumours, and how that experience is now translated into the current COG AGCT 1531 study. So germ cell tumours are a real mixed bag, a heterogeneous group of tumours. As you know, they all arise from molecular defects in the primordial germ cells, which would eventually develop into gametes, either eggs or sperm. And then there has been a disruption of that pathway that allows the formation of this heterogeneous group of tumours with differences in age distribution, location, histology, biology, and clinical behaviour. So we know that there is a bimodal distribution in terms of age. So in the very young children, germ cell tumours make up about 3% of paediatric cancers, so would be considered rare, but that incidence is probably about the same as rhabdomyosarcoma, osteosarcoma and retinoblastoma. So obviously in our practice, we will come across these tumours. But then we know that actually it becomes a much more significant player in the adolescent and young adult group, where it makes up about 14% of these tumours, and then becomes the second most common solid tumour in this group. In terms of location, we know because of the migration of primordial germ cells that these are either gonadal tumours, and if they're extragonadal, will lie in the midline. So about half of them are gonadal, half extragonadal, and about 20% of the extragonadal tumours are intracranial, which I'm not going to talk about in this study. I'm going to focus on the extracranial germ cell tumours. In terms of clinical behavior, we again know that there is a range of histologies and that about 50% of pediatric germ cell tumours are actually benign, so either immature or mature teratomas. But by not being malignant does not mean that they're not difficult to treat. And we know that there are a number of challenges in looking after children who have teratomas, the most obvious of which would be the sequelae of surgery, because the mainstay of management would be surgical resection. And we know particularly for tumours such as sacrococcygeal teratomas, they can be difficult to resect and have very long-term sequelae. We also know that benign tumours can undergo malignant transformation. So again, with sacrococcygeal teratomas, we know about 14% of them will recur with a malignant tumour, and therefore it's important that we do have close surveillance of these patients. And we also know that teratomas can cause real problems with uncontrolled local growth, and they're more difficult because actually we can't apply chemotherapy treatment to them. Often we can try that, but it tends not to be effective. And I've had a couple of patients now who've had immature teratoma. One who was a baby who had just a completely unresectable abdominal tumour and unfortunately died because we really couldn't do anything to take that tumour out. And then an adolescent girl who had kind of recurrent abdominal immature teratoma, which was really difficult to control because every time you surgically resected it, it came back. So there is lots of work to be done in benign germ cell tumours, but I'm going to move on to sort of focus more on the malignant germ cell tumours. So again, just thinking about the location of these tumours, we know that primordial germ cells migrate from the yolk sac to the gonadal ridge through the midline, and that's why disruption of this migration will explain why we see the extragonadal germ cell tumours in the midline. We know that some of the factors involved with the survival and migration of primordial germ cells include things such as a chemokine receptor, CXCR4, and also the KIT ligand, KIT-LG, and this gene has been associated with the formation of germ cell tumours. And again, just a slide to demonstrate the anatomy and the location of these tumours. So as I said before, either in the gonads, and if they're extragonadal, where we see them would be in the sacrococcyx, in the mediastinum, and also particularly in the retroperitoneum. And you can see the breakdown of these locations on the left there. And then you can, there's just a picture there sort of demonstrating that the intracranial tumours are also found midline, so in the midbrain. And then a graph there to show the bimodal distribution of germ cell tumours. So you can see that there's this peak, particularly in testicular tumours in young boys in the very early age group. And then you start to see a rise again as you get into adolescence. And we know that the biology of these tumours, if you compare the sort of pediatric to the adolescent tumours, does look different, and probably these tumours do respond differently to treatment, with the main pattern being that pediatric tumours tend to be more responsive to chemotherapy than the adolescents, and those may be where the high-risk patients lie. And then, as you are aware, we have a number of histological subtypes within germ cell tumours, and this is the other challenge in sort of trying to figure out what is the driving underlying histology of the tumour that you see. We know that they all arise obviously from the totipotent primordial germ cell, and then the level of differentiation will determine what the histology of that germ cell tumour is. So we know that if it remains undifferentiated and in the pluripotent state, that gives rise to a germinoma, also known as dysgerminoma if it's found in the ovary, and seminoma in the testes. Then if you have differentiation of the extraembryonic tissue, that gives rise to the formation of a yolk sac tumour. We know that yolk sac tumours heavily secrete AFP, and then choriocarcinoma, so trophoblastic tissue, which will strongly secrete beta-HCG. beta-HCG is also secreted by germinomas in about 20%. And then if your differentiation is along the lines of embryonal tissue, if that's early embryonic differentiation, then that will give rise to an embryonal carcinoma. And with that, you may see secretion of low levels of AFP and beta-HCG. And then if you get full differentiation, that's when you see the teratomas either immature or mature, and you'll either see sort of immature tissue, or in the mature teratomas, the classic sort of fully formed hair, teeth, nails, etc. And if those teratomas contain either liver or gut tissue, then you may see, or yolk sac elements, then you may see secretion of AFP. And as you're all well aware, then you may also get a mixture of these different histological subtypes, therefore giving rise to a mixed malignant germ cell tumour. And, you know, talking again about the sort of non-malignant components, this can cause some issues. For example, the phenomenon of growing teratoma syndrome. So we know that if you have a mixed malignant tumour, you can control and treat the malignant component with chemotherapy, but then what you might find is paradoxical growth of the mature teratoma component, which then again can be a challenge in terms of treatment. So we are lucky in germ cell tumours that we have a marker that we can measure in blood that can be really helpful in terms of both diagnosis, but also response to treatment, and also then in terms of surveillance. So as I said there, we know that AFP, which is produced by the yolk sac and liver of developing fetus, is secreted by yolk sac tumours and can also be seen in association with embryonal carcinomas and teratomas. Obviously, neither AFP or beta-HCG are universal markers, but AFP is positive in about 70% of non-germinomatous malignant germ cell tumours, and therefore is a useful marker, particularly in the young age group, which tend to predominantly secrete AFP. Obviously, it's important that when we're measuring AFP that we are comparing that to normograms of what we would normally see physiologically, to make sure that those AFP levels are abnormally high, and then we can use those same charts to track the decline of AFP in terms of response for treatment. We know that AFP has shown to be predictive of prognosis in adults, but we don't yet have that same strong relationship in children. It was thought that a high AFP was more predictive of a high-risk tumour, but I'll show in larger data analysis, actually that hasn't been shown to be statistically significant. HCG is, as you know, produced by the trophoblast and therefore seen predominantly in choriocarcinoma. So the commonest clinical situation we see this would be in sort of adolescent boys with mediastinal tumours that have pure choriocarcinoma or an element of choriocarcinoma. And also, as I said, can be seen in about 20% germinomas. So thinking now about kind of what we are understanding more about the biology of tumours, I think very broadly we would say that the biology of paediatric germ cell tumours does seem to differ quite significantly, those from adolescents and adults, and therefore we are not looking at directly the same type of tumours. In terms of SNPs, we know that in genome-wide associations that a number of SNPs in the KIT-LG gene and other genes associated with the normal kind of migration and development of germ cells have been described in germ cell tumours in adults and adolescents. The same kind of how many of these SNPs are also relevant to paediatric tumours remains to be established, because we don't have as many numbers to do those genome-wide association studies. Epigenetic mechanisms probably do contribute to the formation of germ cell tumours, and again we see different patterns in paediatric and more adult type germ cell tumours, for example with imprinting patterns of loci such as IGF2 and H19. In terms of chromosomal abnormalities, we know that chromosome 12p is a gain of chromosome 12p, is a universal finding in adult testicular malignant germ cell tumours, and that's irrespective of underlying histological subtype. But that 12p gain is can be seen in children but tends to be less common, but we know that the frequency does increase with increasing age. And then there are a number of other chromosomal abnormalities described in children as I've put there on the slide, but what their clinical relevance is yet to be established in terms of thinking about prognostication or outcome according to whether you carry those abnormalities or not. What probably is further along in terms of thinking about signatures. A really important part of kind of emerging knowledge of the biology of germ cell tumours is the messenger RNA and gene expression, and there have been described quite clearly different gene expression profiles for different types of tumours. So you can see here the heat map for yolk sac tumours and germinomas, and the gene expression involved will be genes for yolk sac tumours that are involved in proliferation, lipid metabolism, and cell differentiation, for example, whereas in germinomas you tend to see expression in pluripotent genes. And what you can further do is differentiate the different histological subtypes, but then you can also get different gene expression profiles for both pediatric and adult tumours. And then in addition, we know that in adults, we've been able to create gene expression profiles that can have prognostication, so that can predict what the survival outcomes are. And there's work looking to validate those gene expression profiles, and also work to do the same in pediatrics, so that we may be able to apply risk stratification based on the mRNA profiles. And then another really exciting area of research is looking at microRNAs in germ cell tumours. So microRNAs are short non-protein coding RNA that control the expression of messenger RNA. And within germ cell tumours, the LET7 tumour suppressor family of microRNAs, these clusters are expressed in all malignant germ cell tumours. So as I talked about before, there are some limitations for the tumour markers we have currently, but actually we know that these microRNAs are seen in all malignant germ cell tumours. And if you look at the heat map here, you can see these are in pediatric tumours and these are in adults. So there's low or no expression in gonadal or gonadal controls or teratomas. But that in the malignant germ cell tumours, you can see that there is expression of these clusters of microRNAs in both pediatrics and adults. And these microRNA levels can be measured in serum, and so are at high level, have been shown to be at high level at diagnosis, will fall in response to treatment, and then can be detected again if the patient were to have a relapse or a recurrence. So this is really exciting in terms of a blood-based biomarker that means that we can earlier detect these tumours and also track their response to treatment, and also be able to detect very early on if there is relapse without having to rely on imaging. So that's a kind of really exciting part of current germ cell tumour research, and these biomarkers will be prospectively looked at in the current paediatric and adult germ cell tumour studies. So in terms of the treatment, we know that alongside surgery, that the mainstay of treatment for malignant germ cell tumours is with chemotherapy, and that this is very, very effective, that these are very chemosensitive tumours. The real breakthrough with men with disseminated testicular germ cell tumours that traditionally had very poor outcome was, as you know, in the 1970s by Einhorn and Donahue, using cisplatin, vinblastine and bleomycin, and that dramatically changed the outcomes of these tumours. And then etoposide replaced vinblastine to give BEP chemotherapy that we're all very familiar with in the use and the treatment of germ cell tumours. But this, high rates of cure associated with the use of BEP is also associated with very significant toxicity, and importantly, that can be very long-standing. So we know that cisplatin is toxic to hearing, kidneys, and nerves. And if you look at large studies looking at the outcomes, survival of young men with testicular tumours, you know that those treated with BEP have a twofold increased risk of cardiovascular disease and secondary malignancies, mainly associated with cisplatin chemotherapy. And unfortunately, early attempts to replace cisplatin with carboplatin in adults was unsuccessful, and therefore there's a sort of nihilism that felt that actually carboplatin was not an effective replacement for cisplatin. For a long time, particularly in the adult community, there was really no interest in using carboplatin to ameliorate the side effects of cisplatin. But actually, if you look back at those studies, the dose that was used, the frequency and the intensity was much lower than that in which we're using carboplatin in children. And so it's likely that carboplatin was dismissed early, where actually it may have an important role for these tumours. So when we've applied BEP chemotherapy to children, we've been very mindful of the fact that it is a toxic chemotherapy treatment. And as you know, for the younger age group, the bleomycin is used weekly rather than every 3 weeks. So the nomenclature of that would be PEB rather than BEP, so using the small b. And in Germany, they actually replaced bleomycin altogether with ifosfamide to give them a kind of pie type chemotherapy that we also see used in intracranial germ cell tumours. In terms of cisplatin, in the US and most other countries treating germ cell tumours, cisplatin remains the mainstay, but we have shown that although it is an effective treatment, and the POG and the CCG studies actually used in double dose for high-risk patients, which did improve event-free survival, but at a real cost, so nearly 2/3 requiring hearing aids and having very significant hearing loss, which was not reduced by the use of protectant agents. And so for a long time now, for 20 or 30 years in the UK, we have replaced cisplatin with carboplatin to give GEB chemotherapy. We also know that another successful strategy, which has been slow to come in the adults, is to omit chemotherapy altogether for stage 1 gonadal tumours. And as you can see there, although these tumours do relapse, you'll save probably about 75% of testicular and about 50% of ovarian tumours from having any chemotherapy at all if they are stage 1. So I talked about the fact that in the UK, we have been using GEB rather than BEP or PEB chemotherapy, i.e. replacing cisplatin with carboplatin. And we've had 2 single-arm studies to show that this has been an effective replacement by demonstrating outcomes that would be equivalent to those by pediatric germ cell tumour groups internationally who've been using cisplatin. The initial GC2 study used an N+2 strategy, so the number of GEB cycles needed to normalize tumor markers and then 2 extra, but probably ended up over-treating patients with a median of 5 cycles. In this study, we also established and supported the outcomes from the US studies that stage 1 ovarian testicular tumors can be managed with upfront surgery alone. And GC2 with statistical analysis seemed to show that poor prognostic factors were AFP over 10,000 and mediastinal site, and the good prognostic factors were germinomas and the young boys with testicular tumours. So this led to GC3, and this applied a risk stratification based on the findings of GC2. And this is our most recent, although over kind of 10 years old study looking at pediatric extracranial germ cell tumours. And you can see there a risk stratification on the factors that I described. And what GC3 wanted to do was surveillance for all stage 1 tumours, so extragonadal as well as gonadal, and then apply a standard number of chemotherapy cycles of GEB, either 4 or 6, according to whether you're intermediate or high risk. And high risk would be all stage 4 tumours, apart from those good players, so the testes under 5 or germinomas or seminomas. High risk would also be AFP over 10,000, again, except for young boys with testicular tumours, and high risk would be any thoracic tumour that hadn't been completely resected. So this is just a sort of breakdown from that study. I think the main points to take from it was that actually, although they wanted to include extragonadal tumours, there was only one extragonadal tumour in the low risk group, and that there was a significant proportion of what were defined as high risk patients. And the other thing to take from this is a very low number of events, which you can see in the survival curves here. So within the low risk patient group, so the completely resected tumours, the event-free survival was 72%, but all of these patients could be salvaged with chemotherapy. So that was showed further evidence that that was a good strategy. And for the intermediate and high risk patients, we showed a really extremely good outcome and cure rate. And that was even if you looked at patients who were non-germinoma, because we know that the germinomas do well, and if you looked at the high risk patients. And about 30% of the patients in this study were also adolescents, so above 11 years of age. So the numbers were small, but that does suggest that carboplatin can be an effective strategy in adolescent patients. So the difficulty when you have such few events is really picking out who are your high-risk patients, because we know in clinical practice, we do have a handful of patients who do not respond to first-line chemotherapy. And so can we establish who those are up front and therefore intensify their treatment up front? So what has been extremely useful, and India has been part of this collaboration, is the Malignant Germ Cell Tumour International Consortium, which basically is trying to pull data internationally to really try and figure out what are the patterns and what are important in the treatment of malignant germ cell tumours. And you can see of this analysis of over 1,000 patients and pooling both UK and US data, that you can clearly see that there is a true high-risk group. So this is different from the high-risk group that I was talking about that was used in GC3, and they do make up small numbers, but you can see from the outcomes here that they do more poorly than the other germ cell tumours that do extremely well. So this high-risk group would be, and this is what we would now consider high-risk, would be patients who are over 11 years, so the adolescent group, who have either stage 4 ovarian or stage 3 or 4 extragonadal. Interestingly, high AFP showed an association with poor outcome, but did not reach statistical significance as a negative prognostic marker, and therefore is not currently considered to be something that should be used in risk stratification. And the other finding was that dysgerminomas, as we know, do well, and that would warrant investigation of therapy de-escalation for this group.
Hi, Sarita. We just running out of time, so if you can kindly present the remaining slides quickly.
Yeah, sure, no problem. So this just shows you what our strategy is currently in the UK. So we're still using either 4 or 6 cycles of Germ, but actually there's a feeling that if you don't respond to the first 4 cycles of Germ, then you probably do need a treatment change. And so the standard of care within the current study would be to give just 4 cycles of chemotherapy. So that's, and this is in the under 11 years, and just showing you in the children and adolescents who are over 11 years, picking out that poor risk group. So the extragonadal tumours or the stage 4 ovarian tumours, and thinking about escalation of treatment for them. So P3 BEP is compressed use of BEP, and then again for germinomas using carboplatin rather than cisplatin. So this is just my last slide, just to talk about AGCT 1531, which is currently open in the US. Unfortunately, not yet open in the UK, but we're hoping that that will happen soon. And I'm not sure if it is open in India, but India was one of the participants for this study. the biggest coup really for this study is to involve the adults as well. So the gynae and the testicular groups have been doing kind of their own thing and had their own staging systems, etc., for a long time. So allowing this collaboration of the pediatric and the adult groups has been really important. In the low risk group, so this includes patients up to 50 years, we're applying what we've been doing in pediatrics for a long time, which is for the stage 1 and in the gynae group, the stage 1 immature teratomas. These patients have traditionally used chemotherapy. So this study will be looking at removing chemotherapy as upfront treatment. So that would be a real practice change in the adults. And then for the standard risk group up to 25 years, again, what is practice changing is the randomization. So this is the first randomization between cisplatin and carboplatin for the treatment of germ cell tumors. So using in the adolescent and adult groups, comparing BEC with BET, and in the pediatric groups, this again would be practice changing for the US and most other germ cell tumor groups by using, again, cisplatin versus carboplatin. So obviously we'll be looking at the toxicity outcomes and really interested to make sure that survival is maintained, which I think, given the UK data, is likely to be the case. And the really important biological component of this study would be to validating the use of microRNAs as a biomarker. So just in summary, just to say that overall these tumours do well, and therefore future research is focused on improving risk stratification and really picking out those players who do badly. I think we're really interested to see what the outcomes are, for example, of the mRNA gene expression profiles, because there certainly remains a group of tumours who are not defined as high risk up front, but then for whatever reason don't seem to respond to treatment. And then we also really need to look at reducing therapy for good risk disease and looking at new strategies and novel therapeutics, which really we haven't as yet established for high risk disease. So thank you very much. Sorry for overrunning. I know that the seminar in general is overrunning a little bit. I'm happy to take a few questions or reply on the chat. So thank you again.
Thank you, Smita. You covered it right from the very basics to the most recent advances. There is one question from Venkat, which I think pertains to the last slide, which is, if you have a pediatric germ cell tumor over 11 years of age, would you treat them as a pediatric germ cell tumor protocol or adult germ cell tumor protocol? And based on your last slide, it seems currently the proposal has been 3 cycles of the capital BEP versus 3 cycles of the capital BEC. Does that sound right?
Yes. So in the adults, actually, it has been, and also with the COG data, looking at the use of in the adolescent group, has been shown that if you are giving weekly bleomycin, so traditional BEP, that 3 cycles is sufficient and you don't need to give 4 cycles. When they tried to do that with PEB, for the younger group, where they tried to drop a cycle and make 3 rather than 4, they found that there were inferior outcomes. So for the children, if you're going to use less bleomycin, or you're going to replace with carboplatin, it seems that actually you need to give 4 cycles. But if you're giving PEP-type chemotherapy, then actually 3 cycles will be sufficient. So that's why you've got the difference between the 4 and the 3 cycles in those 2 different age groups. And your other question was, sorry, was about...
Yeah, no, the other question was actually just been typed, and I was going to ask something related to that, which is about immature teratoma. So immature teratoma, as you know, the pediatric philosophy and the adult philosophy is different, and we tend not to give chemotherapy. So Gargidas asks about immature teratoma with an AFP value of less than 1,000. I will add to it things like, what if it's a grade 3 immature teratoma or a stage 3 immature teratoma? Are there any situations in immature teratoma where you would recommend chemotherapy?
So, I mean, I think that's a really good question. And I think in general, we would say no, because I don't think that there is the data to support that actually using chemotherapy for immature teratoma is an effective strategy. Obviously, in the adult gynae world, they are still using chemotherapy, and there is definitely a school of thought that feels that, especially for the higher grade tumours of these immature teratomas, that we still should be using chemotherapy. But certainly within the paediatric population and within the UK, we've continued to say that we would not recommend chemotherapy for immature teratoma. The only caveat to that is that there have been, a couple of cases where there have been increasing growth, or there's been sort of gliomatosis peritoni, which has been difficult to control as well. And there has been questions about whether we should use Jeb chemotherapy. And it may be that the use of chemotherapy may stabilize the immature components of this tumor. But I think it really needs to be used on a case-by-case basis. I think in general, we would say that there probably isn't an established role for chemotherapy for immature teratoma, particularly in the pediatric setting.
Thank you. And one last question, and in case there are any more, I will probably, for the sake of time, not go to them. So if you can kindly, Dr. Prasant asks, is there any role of pre-op chemotherapy in an ovarian germ cell tumor with extensive intra-abdominal dissemination with negative tumor markers?
So I think obviously what you would, we're often in this situation, aren't we? We've got very large ovarian tumours, or there's dissemination, and we would use chemotherapy up front and defer surgery. So I think that definitely is a role of preoperative chemotherapy. I think what you'd need to do is a biopsy to make sure that if you've got negative tumour markers, that this actually is a germ cell tumour. So I think if you've done a biopsy that's established it's a germ cell tumour, then yes, absolutely. If you can't safely surgically resect it, then pre-op chemotherapy is a very effective strategy. And sometimes what you find is actually that shrinks the disease to the point that you don't need to do surgery at all. So I think that would be a way of managing it, but you do need to establish the diagnosis if you've got negative tumor markers.
Thank you. There's one more question by Dr. Vibha. If you can kindly type it, I'm sure you can see it as well. So we will move on to the next presentation, and I'll request Sarita to answer that in the chat box itself so that everybody else can see it. Thank you.
Okay, great. Thank you so much.